talking about clear cell renal cancer as the main subtype that we deal with in kidney cancer, and the main target of which we look at is VEGF. So this is really the main protein that we're targeting with the use of TKIs, because this is predominantly upregulated in the development of renal cancer. And we've been successful at this in terms of the use of sunitinib and crizotinib in targeting VEGF. And this is a survival curve, so really it gives you an estimation of the time in months that the use of VEGF targeted therapy has improved in patients across the board. And as you can see, the median survival now in patients who are treated with VEGF targeted therapy has improved to around 30 months, which is really something that we never really had before. And certainly we've been trying to improve this, but it does look like we've come about as far as we can, in terms of using VEGF targeted therapy to treat renal cancer. So we've tried to carry out further clinical trials to either improve this data, and all of it is coming about the same, or essentially being negative. And really that brings us to cancer immunotherapy, which really is a specialty interest very close to my heart, and essentially it's what I do. So to explain what cell immunotherapy is, and I'll probably use this chart here to draw it. Essentially, we know as oncologists that the immune system has played quite a pivotal role in the development of cancer. We've probably known about this for the last 10 years or so, but it's probably only within the last 5 years that we've really understood the mechanism of the immune system better, and really had a better understanding of knowing how to manipulate it in order to target the cancer. So what it is that if you can imagine this being your cancer cell, and it has proteins that sit on the surface of it, and one of the proteins is called PD-1. And basically it's this protein that's binding to another protein called PD-1 that sits on the T cells, which essentially are part of the immune system. And essentially it's the combined joining of these two proteins that essentially renders the immune system paralyzed. So essentially the immune system can't recognize the cancer cell for foreign body that it is, and therefore can't attack it. Okay? And essentially what we can do at present is give an antibody which essentially now binds to the PD-L1, preventing it from binding to PD-1, which now releases the immune system and allows the immune system to now recognize the cancer cells essentially and target it and attack it essentially. And this is a diagram that depicts that association between PD-L1 and PD-1. We like to very much describe it like turning on the lights on an otherwise darkened runway to allow the pilot to suddenly see and take off. So the main drug that we've been using in immunotherapy is NPDL-3280A. It doesn't have a fancy name as yet, it will, I'm sure, with time. And this really gives you an overview in terms of how we're actually treating the patients. So we're looking for the PD-L1 protein on these patients. And as you can see, those have been the groups of patients who have been PD-L1 positive, the middle group PD-L1 negative, and the third group all comers. So we haven't really differentiated in that group whether or not they're PD-L1 positive or negative. And unsurprisingly, obviously, it's the group that tends to be PD-L1 positive that tends to have the greatest responses. And this is exciting. So how have we taken that? So we've actually carried out a randomized phase 3 study, which is now closed. It was open in the UK, and this compared nivolumab, which is an anti-PD-L1, to everolimus, which is a second-line therapy option that we have in the management of metastatic clear cell. And we're now analyzing the data, and the results of which will be available probably early to mid of next year. So it's a watch this space. We also know that PD-L1 therapy appears to be associated with other anti-immunotherapy agents, so that, for example, target CTLA-4. And what we're seeing is that the combination of the two actually gives a durable response. So what this graph really shows is that the combination of the two drugs basically results in a decrease in size of the tumor with time. And that's an extended duration that tends to last for quite a while. This is a trial that will be opening. So this is a randomized phase 3, and going back to your question, so this is the anti-PD-1 and anti-CTLA-4. We're so excited about it that we're actually comparing it to the big guns, sunitinib. Okay, so standard of care. So this is a first-line setting, untreated patients, with the primary outcome being overall survival. This is going to be a really big study, and I think it's going to be really exciting because it's really going to tell us whether or not we've found drugs that are predominantly better than what we have at the moment. So this is opening soon. So we know, going back to our original survival curve, which looked at VEGF therapy, so we know that VEGF therapy works. We know pazopanib's good, sunitinib's good. Can we now combine what we do know is good with PD-L1 to maximize the effect? And essentially that's what we're doing currently at BART. So this is Tom's RAPID study, which is currently open to recruitment at Barnes Hospital. So this is a phase 2 randomized first-line study, again in metastatic clear cell cancer, and patients are randomized to either to receive a VEGF inhibitor, PD-L1 antibody, or PD-L1 antibody plus the VEGF. And we're now recruiting